todos, bienvenidos a esta nueva aula virtual. En esta oportunidad estaremos con el profesor Matthew Kiernan, el principal experto en ELA de Australia y presidente del Comité de Investigación para la ELA de la Federación Mundial de Neurología. Va a estar respondiéndonos preguntas acerca de este muy interesante compuesto que es el Triumeq, que se encuentra en fase 3 de ensayos para la ELA. Gracias, doctor Kiernan, por haber aceptado esta invitación de la Asociación ELA Argentina. Y gracias a ustedes.
Well, thanks very much to the Association ELA Argentina for inviting me along to come and talk to you. I'm very honored and I look forward to the discussions and the Q&A later on. So I suppose everything has a debt to offer, and this is Charcot, Jean-Martin Charcot, and he's working here at the gunpowder factory, Salpêtrière Hospital, and that's where he discovered and coined the term amyotrophic lateral sclerosis, which is why we're all here today for the discussions. So he was an incredible neurologist, but he's helped us to understand what the mechanisms of the disease are, and that's what I'll be touching on a little bit in my talk. So I bring with me greetings from obviously the neurosciences community here in Australia. I'm based in Sydney. My laboratory and hospital are just here, so we look over the Harbour Bridge and the Opera House. I think one of the more exciting things we've been doing over recent years is we've established the Pan-Asian Consortia for the treatment of ALS. So we've brought together China, Japan, Korea, Indonesia, Malaysia, Australia. This area accounts for 3/5 of the world population. But it's amazing that very little is known about ALS in this region. So that's one of the things that we are taking forward at present. I'm also currently chair of the World Federation of Neurology ALS Group Research Committee. And we've been working to try and simplify diagnostic guidelines for ALS, which I will touch on. So back to Charcot, he saw 13 patients in his lifetime with ALS, but he followed them in incredible detail. And the technology of the day was post-mortem examination. So he'd studied the patients and then he looked at them pathologically. And this is his slide. So he knew that there was muscle wasting, amyotrophy, and he found that there was problems with the anterior horn cell. So that's the lower motor neuron. But then he also felt that there was hardening or sclerosis in the lateral part of the spinal cord and brainstem. And that's the upper motor neuron component, the involvement of the corticospinal tract. So he brought this idea together, amyotrophy, lower motor neuron, lateral sclerosis, upper motor neuron, to term amyotrophic lateral sclerosis. It's really the only disease in neurology that goes across both compartments of the nervous system. And the reason I mention this is that it makes it very complex and hard to understand. And that is why it has taken all of us so long to come up with the appropriate therapies. But I think things are changing. From Charcot's time, the next big discovery was in the early 1990s, the discovery of genetic mutations linked to ALS, particularly superoxide dismutase, which is on chromosome 21. Now, no one really understood what SOD1 did. So they looked up the biochemistry and realized that it was involved in redox pathways and glutamate. And so then groups started to measure the glutamate in the cerebrospinal fluid of ALS patients, and they found that it was increased. And this led to the concept of excitotoxicity, that the motor neuron is triggered and it starts firing away. It releases a lot of glutamate, and glutamate is toxic to the motor neuron, and that causes the cascade of death of the motor pathways in the brain and spinal cord. Now, as mentioned, we needed, as a community, to come up with diagnostic criteria, and these started in the 1980s and 1990s, and the first major one was L-Escorial criteria, but there's been Early-House criteria, Awaji criteria, and they've all used a stratification system. So suspected ALS, possible ALS, probable ALS, definite ALS. And this was very confusing for patients and for clinicians. Did they have ALS or not? And some patients were told they had possible ALS and they would never become definite or probable. So on behalf of the World Federation of Neurology, we convened a group to try and look at the diagnostic criteria to simplify them. And we met in the Gold Coast in Australia. And we came up with a very simplified definition and consensus criteria for what ALS represents. So ALS is progressive motor impairment, and that's documented by the clinical history or repeated assessment. And it's preceded by normal motor development. So someone is born normally and they have normal motor milestones, and then sometime in their adult life, they develop a progressive motor problem. They must have evidence of upper and lower motor neuron dysfunction. So this refers back to the Charcot idea. And then we need investigations to exclude other disease processes. So this gets rid of the stratification. It's either ALS or it isn't ALS. And this now has been validated in communities in North America, in Asia, in Europe, and it is now being incorporated as the criteria for patient recruitment into clinical trials. The criteria are freely downloadable, and that's the reference there, so you can all read it and have a think about it. I suppose from a clinical perspective, we see patients once they have developed weakness, so it's down here, and then there's progressive problems, typically 2 to 3 years. But what we don't know is what has happened in the course of their lives over the past decades. And we go all the way back to conception, in utero development, hormonal exposure, the maternal environment. There are parts of how the brain is formed that are most likely contributory to the development of ALS. Obviously, there are epigenetic and environmental factors that are contributing, but we're not sure how much earlier, before weakness, this condition begins. And that has slowed our approach to therapies. But if we can get a marker that, for instance, someone will develop ALS in 5 years' time, our therapies are more likely to be successful. And that is the focus of many people's research at present. Now, a typical idea when I started neurology was that ALS was a neuromuscular condition. And the phrase was that the patients are paralyzed in a body, but their brain is intact, their mind is intact. But what we have really found out over the last decade or two is that there are significant behavioral and cognitive changes that are involved and affect patients. And this was actually discussed in the early 1990s. And these particular papers by David Neary and Julie Snowden, they said they noticed there were behavioral changes. The prospect of mental changes added further to the burden of MND. So they decided not to study this anymore because it was so controversial and difficult. But I think it is important, and we know from the genetics that C9 open reading frame 72, C9ORF, links frontotemporal dementia with ALS. And this was actually a Brazilian occupational therapist, Ineda Miyoshi, who came to work with us in Australia. And she talked to all of the carers of the patients that we were seeing and asked, did they notice changes in their partners? And they said, for 5 years before they developed weakness, they had noticed that the patients had become withdrawn, they had suggestive remarks, they were impulsive, but mainly issues of apathy and mood. So we know that patients develop behavioral and cognitive changes many years before they develop motor weakness associated with ALS. So these are giving us little clues to how we can come up with understanding a pre-ALS condition. Now, I mentioned the Pan-Asian consortia. So we've now linked the databases from these countries. And this was a study that we undertook with about 13,000 ALS patients from South Korea, Japan, and Australia. And we found if you look at the log of the incidence versus the age of onset, it's a linear relationship. And the slope of the relationship is 6. So that means 6 things have to happen to someone for them to develop ALS. If they have a genetic mutation, that accounts for 3 of the steps, but we don't know what the other 3 steps are. So we can't identify why does someone get ALS? Because obviously when you give a patient such a diagnosis, they say, why have I got ALS? And these are the issues that we need to unpick to understand who gets ALS. Now, I mentioned that when I started, ALS was regarded as a neuromuscular condition. But I think more and more with understanding the behavioral, cognitive, and the genetic mutations, we have been saying that motor neurone disease begins in the motor cortex, with anterograde spreading forward, excitotoxicity through the corticospinal tract to the spinal cord, and then the subsequent wasting and weakness. But there are changes going on in the brain for years before the weakness begins. So we have been looking at ways to study brain function. Now, obviously, for an MRI, sometimes you find that there are these changes here, signal change in the corticospinal tract. That means that there is involvement of the corticospinal tract. This doesn't happen very often, but if you see that, it's definitely ALS. We have been looking at function of the brain using transcranial magnetic stimulation. So to activate the motor neuron in the cortex with a magnetic coil. And when we study patients with ALS, they have reduced inhibition. So their brain is hyperexcitable. And then when we start them on riluzole, there is a sort of normalization. Their inhibition becomes more, but this does not last for very long. It lasts for between 3 and 6 months, and ultimately the effect of riluzole wears off. But that's showing us again, getting us insight into what is happening in the brain of ALS patients. And this has been taken forward by a number of groups, including Ammar Al-Chalabi, looking at the King's database in London, showing that riluzole has benefits for patients at all stages of the disease. So right from the beginning through to the late stages of ALS. So it's a very interesting but important medication because it protects nerves. But importantly, protection is great when you have the biggest populations of neurons to protect. So the earlier this medication starts, the better the outcomes for patients. Now, we've been looking at why so many trials have not worked in ALS, and part of the reason is that we just get a whole group of patients and we put them on a medication. Some do well, some do badly, some have no benefit. We now realize we have to stratify patients based on various biomarkers. So it might be based on a cognitive involvement, it may be based on the size of their peripheral motor potentials, etc. And until we better understand how to stratify patients, we are going to be struggling. That's what we've been doing, looking at better stratification for patients, and that includes the genotype. Now, riluzole was the first medication approved in the early 1990s by the FDA. The second medication, which only happened a couple of years ago, was edaravone from Mitsubishi Pharma. Now, edaravone is also reducing excitotoxicity in ALS. It's a free radical scavenger. The clinical trials have shown that it's best in the phase 3 studies for younger patients with normal respiratory function. So ideally, patients in their 50s to 70s with normal respiratory function early in the course of the disease. It's not yet approved in Australia, but we are now with the Therapeutics Goods Administration, and obviously it's not yet approved in Europe. But that is, many of my patients have got access to edaravone by getting it sent from Japan, and they are having it intravenously at home, infusions 14 days per month for 3 months. Another exciting compound is nanocrystalline gold, CNM-AU8. We started a phase 2 study in 2020 through right in the beginning of the pandemic. It's called Rescue ALS, and this was completed. It was a 36-week study of nanocrystalline gold. So nanocrystalline gold increases the energy processes of the brain. It stops the clumping of TDP-43. When we did the trial, there were no dropouts of patients. So normally in a trial, you expect about a 20% dropout of patients. No patients dropped out. There were no deaths in the trial. We've now continued on open label extension for about 180 months. I presented this data in April at the American Academy of Neurology. There seems to be about a 70% improvement in survival for patients who are treated with nanocrystalline gold. What we need to do now is a large phase 3 international study, which we are in preparation for launching hopefully in the next year. But this is the Kaplan-Meier curve showing these are the patients who are nanocrystalline gold. This is the NCALS model, the predicted survival, and this is the benefit at 130 months. So it's quite a significant difference. These studies will be published in the next 6 to 12 months. The other study that we are undertaking at the moment is the Lighthouse 2 project. So we did the Lighthouse 1 project in Australia. We recruited 40 patients and started them on Triumeq, which is a therapy for HIV. The reason we did this is that we know that about 6% of our DNA as humans is made up of endogenous retroviruses, which have been accumulated through evolution. And when we study these in ALS patients, all of the markers of endogenous retroviruses are upregulated in ALS. So there's evidence of inflammation in the brain. Now, when we did our phase 1 trial, it was done to make sure that the introduction of Triumeq would be safe and tolerable. So there were no significant side effects in the patients. They're all taking riluzole as well. So it worked well with riluzole. And then we looked at various outcome measures. I would say that the study only had 40 ALS patients, so it was not powered to talk about survival. But looking at, again, some of the markers of outcome, there were trends for improvement, but that's all we could say. So there is now a Lighthouse 2 study, which is recruiting internationally, aiming for, again, between 300 and 500 patients worldwide to see whether it has a more meaningful effect in survival. So what I would say in conclusion, that our understanding of ALS is significantly evolving, and we're making a lot of improvements in our understanding. And I think the community awareness has increased because of the issues like the Ice Bucket Challenge and greater community and philanthropic support. As I mentioned, we have now diagnostic consensus guidelines to accelerate patient involvement into clinical trials. We are diagnosing ALS quicker. There is not the diagnostic delays that we have seen previously of 14 months of patients. We need to diagnose patients quicker. Obviously, our understanding is improving by incorporating information and knowledge across the globe. And I think we're lucky that pharma are investing a lot more into therapies and trials. 15, 20 years ago, we were lucky if we had one clinical trial. At present, in my group now, we have 7 clinical trials underway. So there's a lot more work underway. And the other thing I would say is patients who are on clinical trials, even if the trial is negative, they're doing better than the historical alternatives. So the patients on placebo are doing much better than they did 5 years ago. So the standard of care for ALS patients has significantly improved. So that's a bit of a background to what I'm doing at present, and I'd be very happy to answer questions.
Hola, soy Ernesto Velasco, soy de Mendoza. Estoy diagnosticado con ELA desde enero de este año en Fleni, en Buenos Aires. Actualmente estoy con tratamiento de riluzole y con edrabona vía endovenosa. Estoy por el sexto ciclo. Hemos conseguido que nos autorizaran otros 6 ciclos más. Estoy afectado en las motoneuronas inferiores y bueno, quería saber si este nuevo medicamento se complementa con estos otros que estamos tomando.
Well, it's a good question. And our experience from the first Lighthouse study is that Triumeq works very well with riluzole. So that's a definite. Separately, a number of my patients have been importing edaravone and getting it like you are. So on my experience to date, there have been no issues with Triumeq, edaravone, and riluzole all working together. In fact, all of those medications are very well tolerated. They have very low side effect profiles. So I would say that if you can get access to the medications, I would definitely take them.
¿Y qué parte es la que, o sea, hacia qué motoneuronas está dirigido? Porque sé que hay ciertos medicamentos que son para las superiores, otro para las inferiores, otro para las vulvares.
Again, good questions. There is no answer, unfortunately. So Triumeq has a systemic effect. It's reducing inflammation. It is active in both the central and peripheral nervous system. So I suspect that it is working both on the upper and the lower motor neurone compartments. But we don't know. Separately, there hasn't been dissection yet of if there is a greater benefit for bulbar versus limb onset disease. So that will be worked out in the current Lighthouse 2 study.
Saber cómo está, en cuánto tiempo puede estar ya a la venta o cuánto más van a durar esos ensayos.
I would say it's at least probably 12 to 18 months. Whilst it's very good, we have many trials. The bad thing is that they're all competitive. So patients will choose which trials they want to go on. So if there are 7 trials and one of them is Triumeq, then patients may, for other reasons, choose, different therapies. They might choose cytokinetics therapies. They might choose masitinib. They might choose, a whole range, genetic therapies. So it's a competitive environment. And as a result, recruitment will be slower for the Lighthouse study. So it will take a while.
This is my question. Out of the trials you are involved in, which of them you would say is more advanced right now and has gotten the larger amount, the larger number of participants, the largest number of participants?
Well, that's a very good question. A number of these trials are part of international consortia, so I can't give all the numbers for all the various countries. If you said to me, what is the most exciting approach at present, I would say it's the nanocrystalline gold. I haven't seen the sort of figures coming out that I've seen from the phase 2 study. As I said, we need to get the phase 3 funded and underway internationally. It is a blue sky approach looking at energy processes in the brain, and it makes sense. It has a good pathophysiological basis. But the reality is, what medications can people get access to? So I would take, if I could get access to any of the medications, I would put myself onto them. So, and that includes edaravone. If I could import edaravone, I would take edaravone. Obviously, riluzole is approved. I'd be taking riluzole. Triumeq is available. I would get Triumeq. And you can approach the companies directly and ask them for compassionate access to medications. That obviously depends on your interaction with the company directly.
And what is a similar question to the one they made before about on Triumeq? So what is the current state of the CNM AU8 clinical trial?
So I think we'll be embarking on the phase 3 clinical trial, multi-international sites, next year. And obviously it's about a 36-week duration. What I would say is there's a number of discussions underway as well with the Food and Drugs Administration, FDA, in the United States. And people need to come up with more directed ways to shorten the length of these trials, because the trials are very long. And as a result, it takes us a while to get all of the patients recruited and then through to complete the trial before we can even look at the data. And that process there is within 3 to 5 years of, starting a trial. So it's very frustrating, not for patients, completely understanding, but very frustrating for all of us.
Based on what you just said, the first thing that comes to my mind is the platform trial approach. So what would it take to have platform trials all over the world? Because it seems to be the kind of design that speeds things up, right?
Yep. Well, I think it's very easy to say how do you spread it around the world? I mean, basically, it just relies on funding. So the platform study in the Healy Center came courtesy of a $53 million US investment. We are launching All-Star in Australia, which is a platform facility, and we're supported by the Australian government funding, but we don't have the 53 million. But what we will do is we will gradually introduce these studies. So we are going to start, our first study is going to be lithium in UNC13A ALS patients. Then we hope to add on nanocrystalline gold. And we are also undertaking, we're in discussions with another couple of companies, which we hope then to add on. So you're right, Pablo, the approach is the platform trial, but it sounds easy. It's very complicated and expensive, and you need to have the appropriate infrastructure, which basically requires funding. So I think we need to push on our colleagues who are very successful in industry and ask them to think about supporting through philanthropy these important initiatives.
But maybe I am a little bit naive or something, but isn't a platform trial cheaper in the long run?
Sure, it is cheaper, but like the nanocrystalline gold study, which we did, was of the order of 5 million Australian dollars. And if you do 3 or 4 of them, that's then 15, 20, and you might be able to reduce some of the costs down a little bit, but you're still looking at, significant investment. And obviously for the international pharma studies, the dexpramipexole study, which we did with Biogen, was the order of 30 to 40 million. So it's a lot cheaper than 30 to 40 million, but it's still millions.
Mi nombre es Karina Soledad Sotile, enfermera. Estamos haciendo una tesis este año sobre lo que es la enfermedad de ELA. Mi pregunta sería si la droga esta que se va a utilizar ahora tiene algún tipo de edad etaria, ¿no es cierto? Si hay una edad, o sea, si se va a utilizar en todas las edades o solamente va a ser en una edad etaria determinada.
Well, again, most recruitment has criteria, and it's usually they mention ages like 18 to 80. The reality is most patients are going to be in their 50s to 70s. And then obviously they have to have a diagnosis of ALS and usually not too significantly disabled, because the longer the delay from diagnosis to starting a trial, the less neurons there are to protect. So it's more likely that the trial will not be positive. So we want to give patients the best opportunity to have a positive effect from the medication.
So the first time we heard about Triumeq, it really blew our minds, because it was like something so new, so unique. You never think of ALS as a virus, because actually it's not a virus. And so our first question was, how come you can treat, is there any chance to treat a neurodegenerative disease with an ARV therapy? So could you expand a little bit more on the concept of Triumeq for ALS?
There's a long literature showing that inflammation is part of the disease process of ALS. So when cells are degenerating, it sets up an inflammatory response in tissue, so particularly the brain. And these inflammatory cells come to try and reduce inflammation. And so people have thought, if you can try and slow this process down, that perhaps the motor neurons will continue to work for a longer period. Now, all of the trials to date, from people who've used steroids various anti-inflammatory medications, and even ourselves, we used Tecfidera, which is a therapy for multiple sclerosis. So we used Tecfidera in ALS, the TEAL study. Unfortunately, this was negative compared to placebo, although, as I mentioned, when we compared the outcomes to historical controls, it seemed to have a very good effect. But overall, all of the inflammatory therapies have been negative. As I mentioned, endogenous retroviruses are part of our genetic makeup, so they're in our DNA. And this has not been approached before. So can we try and have an effect on the signaling pathways in the DNA to try and reduce the process of activation which occurs in ALS? And then through discussion with colleagues who had been involved in treating HIV patients, they said it would be interesting to see whether some of those medications had a benefit in ALS. And we chose Triumeq because it was well tolerated overall, and it was accessible. And through discussions, we were able to get access through the manufacturer to undertake the trial without paying for the medication. And so that's why we started with Triumeq. It was well tolerated and we had access to it. And I think it's an interesting approach. Endogenous retroviruses also seem to be activated in other neurodegenerative diseases. We've been looking at our patients with frontotemporal dementia, and similarly, there is activation in that cohort. I suppose my hope is that in the future, a bit like cancer therapies, we have 4 or 5 medications that we can start patients on, whether probably at the beginning, it'll be a simultaneous therapy. We have multiple therapies. And then with time, we'll be able to understand which patients respond better to which therapy. So we might say that this patient, based on like your earlier question, maybe it's the bulbar onset who have minimal disease respond best to Triumeq initially. So we put them on Triumeq plus riluzole. Then we add on edaravone. Then we add on nanocrystalline gold. That might be the approach. This is speculation.
But it sounds similar to what other researchers are saying, are talking about the cocktail approach,
Yeah.
which seems to be the future in ALS. So I was going to ask, considering that Triumeq is already in the market, not for ALS, but for HIV, would you prescribe your patients or some of your patients with this drug?
So in my own situation, I'm employed by the Department of Health and the Australian government, and I can't prescribe medications that don't have an indication for a condition. I can prescribe medications in the context of a clinical trial if that clinical trial is approved by an ethics committee. So my approach to this is to prescribe medications in a clinical trial setting with appropriate science to see whether it's beneficial for patients. Of course, I'm approaching this from a clinician working in the field. I'm not a patient. So patients can choose to do what they wish. The only thing I would say is that all data is important. So if someone is going to take medications, wouldn't it be important to try and work out what is happening to that individual? So it should be that patient should be monitored so that we can inform other patients currently, but also patients in the future.
Changing the subject of discussion, you also have done a lot of work on biomarkers. Could you tell us about your work on this area of study and the importance of biomarkers for ALS?
So in about 2018, Hiroshi Mitsumoto from Columbia convened a conference at Airlie House on biomarkers. And one of the conclusions was that every trial from now on should have a biomarker component. Why do we say that? Well, even if a trial is negative, surely we have to, as a community, learn more about the disease and about the medications that we are trialing in patients. So that is my philosophy. Every trial needs to have a biomarker. It may be that the biomarker is an effect of the medication itself. It may be that it's about target engagement. So can we prove that the medication is actually acting on an axon or on a brain? As you say, I've been very interested in biomarkers, and we've explored many. And I think the first one that we really rolled out was a peripheral excitability mechanism. So to look at the channels in the nerves of patients with ALS. And this was utilized in the retigabine study in the United States. So 14 centers in the US used our technology to monitor target engagement of retigabine on persistent sodium conductances. We were the data center for all of the patients. All of the data came to us in Sydney. And that was very interesting. Separately, I've converted my thoughts that the brain is, I think, the most important part of ALS. And we've been trying to come up with mechanisms to look at disease progression in the brain. And as I mentioned, we're looking at this with transcranial magnetic stimulation, both as a diagnostic test and also as a biomarker for trials. In the data I showed earlier, we can see that it can identify the effects of riluzole on the brain. And we want to incorporate TMS in future clinical trials. And it might be that we have to do it at an investigator approach first before it's commercially available. Separately, our other platform that we're really focusing on is MRI imaging. And with MRI, we're also doing MR spectroscopy. So we're looking at glutamate in the brain. And we are trying to develop this as a platform across Asia through Pactals as a biomarker for clinical trials. And I think you'll be hearing more about this in the future. Well, neurofilament is useful for diagnosis. As yet, we don't know whether neurofilament can identify a benefit of medications in ALS patients. So this is ongoing research. Time will tell.
Excellent. Great. So I guess this might be the last question. This is a question that we traditionally ask to other experts, and is related to gene testing. So the general approach of the field towards gene testing seems to be changing lately. And like 3 or 4 years ago, many experts used to say that if there is only one case in the family, maybe it's not the time to do gene testing for everyone. Maybe relatives shouldn't be getting tested. Maybe there is no point for that. But now with all the gene therapies that are currently being explored, that perspective that seems to be changing, right? So it looks like it makes more sense now to test at least the patient and probably also the immediate relatives. What is your position on this topic?
Well, as you say, this is a very important topic for discussion. In our clinic, we've been testing all patients for genes for about a decade, but we are driven through research and we are funding that through ourselves. So again, that is expensive. The game changer in the field was the discovery of C9orf72. So in a Finnish population in Finland, 46% of sporadic patients, apparently sporadic, express the gene. So we looked at our own population in Australia, 7.5% of sporadic ALS patients had a mutation of C9orf. So that's telling us that we should test for it. Separately, as you say, genetic therapies, the antisense oligonucleotides and so on, are now being introduced for clinical trials. In that setting, it's important to know the genetic background to all patients. So we've been working as part of an international consortia, and earlier this year, we published a statement in Brain, the oldest journal of neurology. It was a multi-authored paper. First author is Christiana Salmon. The other authors are myself, Amar Al-Chalabi, Peter Anderson, Adriana Keogh, Angela Genge, Leonard Vandenberg. And we advocated that all patients should be given the opportunity to undergo genetic testing. And that's the viewpoint that we have. And I think that's the community viewpoint. of course, it comes down to what we've talked to before, accessibility, and accessibility relates to funding. Many countries, so we had a representative on the group, Patricia Leo from Santiago in Chile, and they have no access to test genetics for their patient cohort. The only opportunity would be to send it to international collaborators, but even then, there are restrictions in Chile about what bloods can leave the country. So it's a complicated issue. I think that with our industry partners, we may be able to get to the bottom of this, because obviously if industry therapies are available, ASOs, say through Biogen, like tofersen, they will want patients to be genetically identified. And industry may help working with the community to make genetic testing accessible for every patient diagnosed with ALS. That is the future, and clearly that's what needs to happen.
Excellent. Okay, so
Great.
I think that's it. Yeah, it's been great. Yeah, we talk about a lot of things. So this is going to be really helpful. And again, thank you so much. Thanks again.
Okay.
Thank you so very much. And we will stay in touch. All right.
Sounds good. Thanks, Pablo.
Bye. Thank you so much.
See you.
See
Bye.
ya.